Now I am going to discuss about management of complications of critical and severe COVID-19 patient. I already discussed about the individual management of critical patient as ARDS and septic shock. I already discussed about individual management of severe patient, severe COVID-19. I already discussed about non-severe patient management as mild and moderate case. Now I am going to discuss about the complication which arise during the management of COVID-19 and how to manage that complication. To prevent the complication, you should practice care bundle. If you admit patient into ICU, if you ventilate, if you manage septic shock patient, you have to consider application of care bundle to your patient. What is care bundle? Care bundle is group of intervention, evidence-based group of intervention, usually 3 to 5, when implemented together, give a better outcome rather than implement individually. You can implement it individually, separately, but in that case, outcome is not that much good. When you implement all the things together, it gives better outcome. Not only that, those outcomes you should be auditable. So, definition of care bundle is group of intervention, evidence-based group of intervention when implemented together give a better outcome rather than implement it individually, and it can be easily auditable. It can be easily auditable. You have to practice septic care bundle on your patient. You have to practice ventilator care bundle for your patient. You have to practice septic care bundle for your patient. CVP, ventilator and septic care bundle. There are number of care bundles. You have to practice those care bundle on your patient in order to improve the outcome. Number 2, you have to consider DVT prophylaxis. Deep vein thrombosis prophylaxis, because your patient is immobile. COVID-19 associated with high risk of thrombosis. So, in normal adult, you have to consider 40 mg subcut enoxaparin daily in healthy young normal adult. Once they develop COVID-19, they are not healthy at all. Usual dose is 40 mg per day. But if you found a patient with high BMI, body mass index, more than 40, or body weight more than 120, sometimes you may have to consider double dose, 40 mg twice a day. Or you can consider heparin for your patient. Or you can consider deltaparin, tenoxaparin for your patient. Or if your patient develop heparin-induced thrombocytopenia, you can consider fundoferinax 2.5 mg daily. Or direct oral anticoagulation, you can consider DOAT. So you have to manage your patient DVT prophylaxis. Sometimes you may have to consider therapeutic anticoagulation, not the prophylaxis. If you found a DVT, you may have to consider therapeutic anticoagulation. If you want to start therapeutic anticoagulation for some reason, your patient should have normal coagulation profile and your patient should have normal serum creatinine, because your enoxaparin going to filter via your kidney. If you have impaired renal function, enoxaparin can accumulate. So you have to manage thromboprophylaxis. You have to awake your patient. In that case, your patient early recovery can be provoked. You have to consider active breathing of your patient. You have to consider the coordination with your patient, otherwise your patient can become psychotic. You have to manage delirium. You have to early mobilize your patients. Then you have to consider prevention bundle. Ventilator associated pneumonia prevention bundle, it was mentioned earlier as well. You have to maintain the head tilt up position. How much? 30 to 45. 30 to 45 degree head tilt up. You have to consider sedation interval. You have to consider sedation interval. Daily sedation interval improve the weaning process. You can quickly extubate if you are going to do daily sedation interval. DVT prophylaxis you have to consider to improve the to reduce the ventilator associated pneumonia, DVT prophylaxis. In this patient, the COVID-19 patient, you have to consider the close suctioning, because suctioning is aerosol generating procedure. Otherwise, you contaminate whole area. Close suctioning. And you have to maintain good oral hygiene. You have to clean mouth with the chlorhexidine solution. You have to clean the mouth with chlorhexidine mouthwash. So you have to practice ventilator associated pneumonia care bundle on your patient. Number 6, you have to prevent catheter related bloodstream infection. You have to daily assess your catheter site and daily assess the necessity of the site catheter, whether this patient need central venous catheter or not. Catheter prevention bundle component include site selection. We will try to do here or here, jugular or subclavian. Try to avoid femoral because infective area this is. So try to avoid this area and try to insert here. Site selection, number 1. Number 2, you have to clean and you have to close all the area except the catheter insertion part. Then you have to check daily necessity of your CVP line. Not only that, you have to assess the site daily, whether it is infected or not. Otherwise, your patient can develop catheter related bloodstream infection. Number 7, you have to prevent pressure ulcer. For that, what they recommend is 2 hourly you have to turn your patient. 2 hourly you have to turn your patient. Then stress ulcer prophylaxis. If your patient develops stress ulcers, your patient can develop major bleeding inside and sometimes patient can die. What they recommend is early fading you should establish. In that case, gut become normal tropic action happen there. Because of that, mucosal damage will be minimized. After 24 to 48 hours of critical illness, critical period, you can consider a starting of NGPD. Then you have to start proton pump inhibitor or H2 receptor blockers, histamine receptor blockers. Some people having high risk of developing gastric ulcers, prolonged ventilation, other chronic illness, CKD patients, and patient with GI ulcer already. Those patients having high risk of GI bleeding, you have to consider proton pump inhibitors or H2 receptor blockers in that case. So you have to consider antibiotic. Those patients most of the time can have secondary bacterial infection. You can't start antibiotic empirically. You have to prove whether your patient having infection, co-infection or not. In addition to COVID-19, sputum culture, blood culture, urine culture, you have to repeat the descent and check whether you have patient having additional secondary bacterial infection. If so, you have to start antibiotic. Usual antibiotic costs 5 to 7 days. Then you repeat culture. Don't give unnecessary amount of unnecessary duration of antibiotic. Your patient can develop antibiotic resistance. Your bacteria can develop antibiotic resistance, not the patient. So the last one, check whether your patient having drug interaction or not. Because here the COVID-19 associate with most of the time the elderly people with the severe and critical illness. They are having polypharmacy usually, lot of antihypertensive drugs and lot of anti-ischemic agent, lot of blood thinning agent, aspirin, clopidogrel. Check whether those are drug interaction with your drug. That is all regarding the management of patient with prevention of complication of patient with critical and severe infection. Thank you very much.